Endocrinology. Endocrinology. 1. Pituitary. 2. Pancreas. 3. Thyroidism. 4. Parathyroid. 5. Adrenals. 6. Emergencies. Pituitary microadenoma, 10 mm. Hashtag $% and %. Adenoma, non-functioning absence of any clinically significant hormonal hypersecretion cause clinical problems due to mass effect, headache, visual field defects. Malignant tumors are rare. Treatment, surgery, if with significant mass effect or fast-growing tumors. Continuous monitoring. Continuous monitoring. Adenoma, functioning. Prolactinoma may be due to stress, pregnancy, lactation, meds, antiemetic, antipsychotics. Clinical features: galactorrhea, oleo/amenorrhea, male hypogonadism, low libido, erectile dys. Investigation $0% 1 hashtag 23, MRI, to determine the presence of a pituitary tumor. If present, check for the size. Treatment: dopamine agonist, cabergoline, 85% shrink, 85% normalizes hyperprolactinemia. Surgery, if resistant to or with significant adverse effect from medication. Acromegaly due to high GH secretion. Clinical features: pubertal, gigantism. Investigation for hashtag $*/56. Treatment: refer to endosurgery, radiation, long-acting injectable somatostatin analog alt, pegvisomant. Cushing's disease due to an ACTH-secreting pituitary adenoma. Clinical features: repubertal, growth failure. More specific, thin skin, easy bruising, proximal myopathy, broad, purple striae, flank, abdomen, breast, upper and lower extremities, vertebral fracture, osteoporosis. Central adiposity, buffalo dorsocervical hump, supraclavicular fat pads, facial plethora, moon facies, hirsutism. Menstrual disturbances, SYCH/mood disorder, hypertension, diabetes, pityriasis, versicolor. Investigation: best screening, 1 mg overnight dexamethasone suppression test. Os dexamethasone morning, cortisol 15 mol/L excludes Cushing's syndrome. If 1 mg dexa suppression test is not suitable, 24-hr urinary free cortisol or late night salivary cortisol, at least 2 sx. Treatment: refer to endo. Treatment goals: 1. To establish that patient has a pituitary source. 2. To determine if post-surgical remission has been achieved. 3. Manage patient for whom surgery does not result in remission. MDT pituitary service: high recurrence rates even after surgery. Hypopituitarism most common mechanism, obstruction. Clinical features, depends on what hormone is deficient. Investigation: pituitary function panel drawn before 9 a.m. UEC, FBG cortisol, plus/ACTH, free thyroxine, TSH prolactin, FSH/LH estradiol/testosterone IGF-1, plus/GH. Treatment: refer to endo MDT. Pituitary apoplexy endocrine emergency cause, acute sudden pituitary hemorrhage or infarction. Clinical features: sudden headache and hypopituitarism w/or without vision loss, eye movement disorders, altered level of consciousness. Investigation: CT scan to exclude SAH. Treatment: urgent glucocorticoid replacement. Refer to endo and neurosurg. Surgery if no improvement of visual changes with conservative management. Pancreas. Diabetes mellitus definition EAP1 diabetes, results from SS cell destruction due to an autoimmune process usually leading to insulin deficiency. EAP2 diabetes, results from a progressive insulin secretory defect on the background of insulin resistance. Gestational diabetes mellitus, GDM, defined as glucose intolerance with onset or first recognition during pregnancy. Auditriske, A equals 4BC 54DE hashtag %$FG $$3E hashtag %E3 and high 3G $3 EKLF $$ and M1 %03, J2 and 0G and 302E, pi F %11 Q3, J0 $01 1E hashtag E3 and $2 I3G pi F %11 Q3. Eopal taking antipsychotic medication Aboriginal and / or Torres Strait Islander people. Risk score, risk of developing type 2 DM within 5 years. C. Diagnosis, type 2 asymptomatic patients TOA-#U, VW9SX, %1Y, %1 at %2Q %E0 $2 hashtag Symptomatic patients, one of the following is confirmatory of a diagnosis of diabetes patient presenting with hyperglycemic crisis E3, J11M2 and 7Z6. %1Y. J1 TOA-#U, VW $, and %01% and clinical symptoms suggestive of diabetes lethargy, polyuria, polydipsia frequent fungal or bacterial infections lead vision OSS of sensation, i.e. touch, vibration, cold, or wound healing aid loss. Diagnosis, type 1 diabetes considered a disease of children and the young, however, the majority of people with type 1 diabetes are adults, and as many as 42% of type 1 diabetes cases have their onset in people between 30 and 60 years of age. Ketonuria, which may be absent, oliguria, polydipsia acute weight loss, 5% in less than 4 weeks, 50 years of age arsenal and family history of autoimmune disease acute onset of symptoms. Glucose monitoring. HbA1c targets. Management. Pharmacologic treatment. Practice point: what if medication is not working? The review rule is a call to action. In addition to replacing or intensifying therapies, consideration should also be given to deprescribing when appropriate. If, despite optimization of medication or lifestyle intervention, glycemic objectives are not being met after 3 months, 6 months at the most, review and check the patient's understanding of the medication, its indication and dosing regimen, health literacy. Assess persistence and adherence to the therapeutic regimen, including lifestyle modification. Exclude potential confounders, such as occult infection, e.g. urinary, medications that might interfere with glucose control, e.g. steroids, some antipsychotics, or the presence of unmanaged obesity. Consider alternative diagnoses if not done previously, such as latent autoimmune diabetes of adults, LADA, or maturity onset diabetes of the young, MODY. Assess tolerability and safety, particularly hypoglycemia, and other factors such as planning for pregnancy or adverse effects that might impact patient engagement. The review rule emphasizes that optimization of the current regimen, including lifestyle modification, should be implemented before advancing through additional glucose-lowering medicines to achieve HbA1c targets within 3 to 6 months. Insulin therapy: set an individualized target, start low, go slow to gain patient confidence and reduce the risk of hypoglycemia. Select one of 2 insulin schedules, a sol insulin, e.g. Glargine U100 or U300, once daily, irrespective of meals, or formulated insulin, e.g. degludec, aspart, or premixed, biphasic, insulin, e.g. lispro, lisproprotamine or aspart, protamine insulin, once daily before the largest carbohydrate-containing meal of the day. Premixed insulins have various combinations of intermediate-acting basal insulins and rapid-acting insulins. Common combinations are 25/75, 30/70, and 50/50, rapid-acting/basal insulins, by percentage. Insulin titration by regimen: basal, intermediate or long-acting insulin, adjust the dose based on previous average fasting glucose levels. Premixed insulin at breakfast and dinner, adjust the breakfast dose based on average previous dinner readings, as long as a dose increase does not cause hypoglycemia at lunchtime. Adjust the dinner dose based on previous average fasting glucose levels, as long as a dose increase does not cause hypoglycemia at bedtime. Basal, bolus, rapid or short-acting insulin is used for bolus dose. Adjust the dose at mealtime based on the previous day's glucose level measured either 2 hours after the corresponding mealtime or before the next mealtime, e.g. adjust the breakfast dose based on the previous 2 to 3 days' average 2-hour post-breakfast value or the pre-lunch value. CVD risk assessment: management, lifestyle modification, physical activity type 1 and 2 DM, engage in 60 minutes per day of moderate or vigorous intensity aerobic activity, with vigorous muscle strengthening and bone strengthening activities at least 3 days/WK. Adults with type 2 DM, 150 minutes or more of moderate to vigorous intensity aerobic activity per week, spread over at least 3 days/WK, with no more than 2 consecutive days without activity, 2 to 3 sessions/week on non-consecutive days, for a total of at least 60 minutes per week. Prolonged sitting should be interrupted every 30 minutes for blood glucose benefits, particularly in adults with type 2 diabetes. Flexibility training and balance training 2-3x/WK for older adults with diabetes, yoga and tai chi. Diet. Cereal foods: approximate 3 serves/day of whole grains, at least 1.5 serves/day of dairy foods, e.g. milk, yogurt, cheese. Weight management: medication may be considered in people with diabetes and overweight or obesity to promote weight loss and improved glycemic control. Metabolic surgery should be recommended in Z5s BMI 35.0 to 39.9 when hyperglycemia is inadequately controlled by lifestyle and optimal medical therapy. BMI 30.0 to 34.9 if hyperglycemia is inadequately controlled despite optimal treatment with either oral or injectable medications. Smoking cessation, alcohol consumption, up to moderate amount. Antihypertensive medication BP target, 140/90 mmHg for people with diabetes, with lower targets considered for younger people and those at high risk of stroke. For SEC prevention of CVD, target BP for people with diabetes and microalbuminuria or proteinuria, emergent chronic kidney disease, remains 130/80 mmHg. Lipid-lowering medication first line, statins other meds, DM plus ACS, add ezetimibe, plus simvastatin, cannot tolerate statins, nicotinic acid, bile acid resins, fibrates 5-FBA6, G, carrot, %1YR and F, %F30$2. Antithrombotic therapy, glucose-lowering medications that show novel non-glycemic effects. The diabetes cycle of care. Thyroid 6. Hyperthyroidism A causes. B. Investigations TSH, FT4, FT3 thyroid ultrasound, indicated to evaluate suspicious structural thyroid abnormalities, nodules. C. Management indication for referral to endo patients aged 18 years or less, patients unresponsive to therapy, pregnant patients, cardiac patients, presence of goiter, nodule, or other structural changes in the thyroid gland, presence of other endocrine disease. First line for Graves' disease, antithyroid medications, carbamazole PTU, due to less hepatotoxicity, pregnancy, PTU, first trimester, AE, agranulocytosis baseline, FBE, LFTs or 12 to 18 months, with treatment continuing until the TRAb becomes undetectable. Radioactive iodine ablation, I-131, considered in the FF, ILR to achieve a durable remission despite prolonged or recurrent courses of thionamide therapy. A. Current Graves' disease, individuals who are unable to tolerate thionamides because of adverse effects. Takes 3 to 6 months to induce a hypothyroid state, and some individuals will need more than one dose. Corticosteroids should be given prophylactically at the time of radioiodine therapy to reduce the risk of a flare of orbitopathy in individuals with mild orbitopathy. Hyroidectomy considered in the FF, adherent to severe Graves' orbitopathy. Women who desire a pregnancy within the next 6 to 12 months are goiter causing compressive symptoms or goiter with significant retrosternal extension. Here thyroid malignancy is suspected. Hen patients are fearful of taking radioactive medication. Toxic nodules preferred, radioiodine, best chance of achieving the euthyroid without medication, surgery, very large goiter and / or significant compressive symptoms, and for those who do not want to have radiation therapy. Long-term thionamide therapy, elderly people or in individuals who prefer to avoid radiation or surgery. Percutaneous ethanol therapy or laser therapy, but not available in some parts. Thyroiditis causes, autoimmune, viral, medication antithyroid, ineffective, inappropriate beta blocker, for symptomatic relief corticosteroids, painful subacute thyroiditis. Hypothyroidism. Causes. Clinical features. Appearance, puffy and pale facies, dry, brittle hair, sparse eyebrows, dry, cool skin, thickened and brittle nails, myxodema, fluid infiltration of tissues. Energy, cold intolerance, weight gain, fatigue CNS, headache, paresthesias, including carpal tunnel syndrome, cerebellar ataxia, delayed relaxation of deep tendon reflexes. Psych, reduced attention span, memory deficits, depression CV, bradycardia, diastolic hypertension, pericardial effusion, decreased exercise tolerance MS, myalgia, arthralgia GI, anorexia, constipation repro, irregular or heavy menses, infertility. See investigations TSH, FT4, FT3 thyroid ultrasound, indicated to evaluate suspicious structural thyroid abnormalities, nodules. Management goals of therapy for hypothyroidism include, amelioration of hypothyroid symptoms, restoration of a euthyroid state void overtreatment. Indication for referral to endo patients aged 18 years or less, patients unresponsive to therapy, pregnant patients, cardiac patients, presence of goiter, nodule, or other structural changes in the thyroid gland, presence of other endocrine disease. Initial dose of levothyroxine of 25 to 50 g/day can be used with a target TSH level between 1.0 and 3.0 μ/L. The TSH level should be measured in 6 to 8 weeks after commencement of therapy, and annual reviews once the TSH level is stable. Parathyroidate. Osteoporosis. Osteoporosis risk assessment, diagnosis, and management, restricted to postmenopausal women and men aged 50 years. Consider bone densitometry if the following risk factors are present: age greater than 70 years, age greater than 60 years for men and greater than 50 years for women, plus any of, family history of minimal trauma, fractures, smoking, alcohol intake. 2. 4 standard drinks per day for men, less for women. Diet lacking in calcium. Our body weight a current falls sedentary lifestyle over many years. Adrenals 9. Addison's disease, primary adrenal insufficiency, MCC, autoimmune adrenalitis D/T decreased glucocorticoid, cortisol, leads to a decrease in vascular sensitivity to norepinephrine and angiotensin II such that peripheral adrenergic tone is reduced leading to vascular collapse and shock. Lack of cortisol may also induce hypoglycemia. Medical emergency and should be considered in any patient presenting with one or more of the following symptoms: precipitated by stress, sepsis, dehydration, or trauma, altered consciousness, circulatory collapse, hypoglycemia, hypoatriemia, hyperkaliemia, seizures, history of steroid use/withdrawal, or New York. Clinical features of Addison disease: hyperpigmentation may be seen, particularly in sun-exposed areas or pressure points. DKA, an acute, life-threatening emergency characterized by hyperglycemia and acidosis. Occurs in people with type 1 diabetes. Presenting feature of type 1 diabetes, especially in younger children, occur in uncontrolled type 2 diabetes. Euglycemic ketoacidosis, plus, ketosis, plus, acidosis, and BGL in symptomatic patients. Likely to occur in patients with type 1 or type 2 diabetes who are pregnant, patients on a low-carbohydrate diet or using SGLT2I, or patients who have just undergone surgery. HHS severe persistent hyperglycemia, in the absence of ketosis, with profound dehydration. Omen in type 2 diabetes in the presence of acute sepsis, after a CV event, MI, stroke, or if with renal dysfunction. Coma may develop in some patients and neurological impairment is common. Mortality HHS DKA. HHS may sometimes occur with DKA in a mixed clinical picture of ketoacidosis and a hyperosmolar state. Risk factors. Assessment vs. Temp, BP, HR, RR, GCS, POC. Preferred POCs. Apillary BGL, critical greater than 15 mol/L, apillary blood ketones, critical 1.5 mol/L. Less preferred, urine ketones, critical 1+. E-management algorithms.